Before we go into endoscopy of our patients, we should address one or two things about coronavirus and endoscopy. We know that the reservoir of the virus is in our nasopharynx, in the nose, and in the upper respiratory tract. Now, going through this tract, transnasal, is dangerous. It's not the going through with the endoscope that is dangerous, but the dangerous part is when you take your endoscope out, or if the patient sneezes and coughs right in front of you. And we know that getting heavy viral load, viral concentration of droplets into your face, so that if you as an examiner inhale that, that's really dangerous. And because of that, we want to take a lot of precautions so that even if something like that happens, we are not in danger. So we now will show you how we do that with our endoscope. We know that with our endoscope type, we have a camera on the tip of the endoscope, which means we watch the monitor, which you can see over here. But we also are aware of the fact that some of you colleagues have the endoscopes without a camera attached, which means you're even closer to the patient's face. And what can you do to protect your patient and protect yourself, of course? What can we do while we are close to the patient? Can we cover the mouth? Can we cover mouth and nose? How do we handle the endoscope when it comes to infectious secretions that we touch? Of course, we have to touch the nose. We are very close to the mask. And can we do that alone? Do we always need an assistant or even two assistants? How do we handle the potentially infected endoscope? How do we handle that over to the assistant? And we will not talk about the cleaning part, because the cleaning part is more or less the same. Another fact that is very important for us is that we have to consider this corona situation as something very new for us. So we learned that infections are maybe the droplets that come directly to us. Everything that we touch is infectious. But we not very often think about the aerosols. And thinking about aerosols in the air, we have to rethink, where are we doing our examination? Where do we take the history? Now, this is a special situation. And given that in most situations you take the history in the same room where you do the endoscopy, this means that your patient, even if we would have masks, that when the patient exhales through this normal nose-mouth cover, that the aerosols are in the air. Now, maybe there are not many aerosols after a couple of minutes, but if the patient sits there, let's say 10 minutes or 15 minutes, and inhales and exhales, then there's this invisible cloud of aerosols. Now, how can we get rid of these potentially infectious aerosols? Of course, we have to open the windows. Now, within the last weeks, we always do all history taking and examinations with open windows, even sometimes with open doors, because we want the draft, we want the circulation. We don't have an air conditioning system that sucks out enough air in a short time. But the air standing and not circulating is something that is not good for all of our examinations. For history taking, I think it's better, because this is a simulated situation, I will take off my mask. The patient has a normal mask, which need not be FFP2 or FFP3. We will have a distance like this, which is at least 1.5 meters. So this is the situation for history taking. Before the patient comes into the examination room, we of course clean our hands and the patient's as well. Please realize that we always have open windows here, and if you have air conditioning, yes, try to ventilate your room, try to have circulation so that the aerosols don't stay here. There's no exact data how quick the aerosols come in a non-circulatory environment from the patient to the doctor, but it could be after, let's say, 5 or 10 minutes, and we don't want to have that risk, so open your windows if you can. Sometimes we also have our doors open, so that even progresses the draft in the room. Just a couple of words to how we decongest the nose. Well, up to 2 months ago, we always sprayed the patient, took a speculum, and then we sprayed, decongested, and then after that we anesthetized with lidocaine spraying. Nowadays it's strongly advised not to spray, because if you spray into your patient's nose, then some of the aerosols and the droplets can come back and infect you. So it's highly advisable to use other methods of decongesting and of numbing. So what do we do now? We use these little monodose decongestants, ask the patient to put it in each nose, or we do that for them, but only in the protected mode, and we don't spray anymore, so we don't use these specula anymore. And for the numbing of the nose, we will show you how we use that with this little syringe filled with topical anesthesia, lidocaine 4%, which we will squirt into the nose while the patient is inhaling. After we take the history, then it comes to the endoscopy. For the endoscopy situation, the patient is already sitting in the examination chair, but then we, and we is always 2 persons, have to change our dressing according to the situation, what we want to do, and we will now show you how we do the normal transnasal flexible laryngoscopy. Okay, now we're coming to the endoscopy situation, and before I start, I will say how we are prepared. We have an FFP3 mask, but you can also use an FFP2 if you don't have a 3 mask. Then we have the eye protection, and we have a visor. We have our hair covered and a single-use gown. We also have 2 pairs of gloves. This is the lower one, this is a snug fit glove, and the upper one is one that I will take off after I numb the nose. We have also prepared, that's very important, non-alcoholic wipes. There's a special technique how to wipe off the secretions. Don't ever do that forcefully with the endoscope, but only wipe off the secretions so that you decontaminate, let's say, the gross secretions and infectious material before you hand over the endoscope to your assistant. The assistant, we always need an assistant. The plan is that the assistant stays non-infected, so he or she can handle all the machines and give me the endoscope, take the endoscope. Sometimes it happens that the assistant is contaminated, and that's why they also should have 2 pairs of gloves, and the blue one and the yellow one. So let's start with the endoscopy. First, I asked the patient to take down the mask from the nose, but cover the mouth, as you can see here. Then we take the numbing agent. I will hold a tissue on the mask so that the mask is not all the way soaked. And as soon as I go in here, as you can see, the left hand is contaminated. Then I will squirt in 1 cc. I will not do that in this case because this is just for demonstration purposes. I will go very close in and then squirt in while the patient is inhaling, and I ask the patient, inhale please. And then I squirt in, ask the patient to swallow, and then I go to the other side and take the rest and inhale, then squirt. And then the patient has
the numbing agent in the nose, and I will ask the patient, please put the mask on for a couple of seconds. Okay, then I will throw this off, and my both hands now are contaminated, which means I get rid of both, and then take this glove, take it off, clean, take it over here, take it off, and throw it away without touching anything. Now they're supposed to be clean, my gloves. Now I take the endoscope from the assistant. We're all not contaminated, so up to now this is a clean situation, but in a second I will contaminate my left hand again, keeping the right hand as clean as possible, of course. Can you please put down? Yes, and cover the mouth, and then I'll have a look on the one side, have a look on the other side, which one I would prefer, and then I do the procedure. I will not show how to do the procedure because from now on this is a normal, regular endoscopy. After I take the endoscope out, after the procedure, then I have a situation that this part here is covered with secretions. Then I take, with my contaminated left hand, the endoscope, and I clean it like this, very softly, gentle. Throw the first one away, and I have the feeling that if I take a second one and even go over this end piece again like this, softly, also including the tip, getting rid of that. This is not the whole cleaning procedure, but this is the, let's say, gross decontamination. And now I have to hand this over in a way that it is put to the cleaning process. So can we see that here? I'll put it into here, to this bag. And then the assistant is taking the endoscope and putting it into a big bin over here. As you can see, the bin has to be covered and then transported outside of the room. And then the normal process of cleaning of the flexible endoscope takes place. There's no difference to the otherwise cleaning process. So in this case, from now on, the cleaning is a normal process. What we can also do when we want to do the endoscopy, and if we don't want to have the patient take down the mask, we can also use that perforated mask that the patient has on, and then do the whole process of squirting the lidocaine into the nose through that little hole, and doing the endoscopy also through this little hole.
Now we want to show you how we do an office-based procedure, and in this case, in this simulation case, we will show you laser surgery in the larynx with a fiber-guided laser. For this, we have a personal equipment, a whole body equipment that also has a hood. I will take it on later, but now for explanation I will also put off the FFP mask so that I can explain everything. I have this kind of equipment covering my body, 2 pairs of gloves as we showed before. I will have the FFP mask, I will have the hood on, and also protective glasses for me. Also for the patient needs protective glasses for the eyes because it's a laser procedure, and then the patient also has a pulse oximeter on the finger. And then I will see the whole procedure on the screen. When I have my hood on, then I want to really make sure that I have as least reflections in the room as I can have, which means the light sources, etc. You have to try it out so that you can see the screen and not your reflections. Inside of the hood, sometimes there's a reflection so that I can see my own mask. Also, we have to be aware of that inside of that hood, while the paper respirator machine pumps air into the hood, I always have this noises which goes on, and I cannot understand the patient as well as my assistant. So we all have to talk loud when communicating. As you can hear in the background, you can hear the siren of an emergency ambulance. So we try to keep the windows open so that we have aeration, but we have to put down all the Venetian blinds because it's a laser procedure. So now we will take on all our protective equipment, and then you will see me and the assistant next to me. Again, I try to be and focus all my contaminated parts, like my gloves, to the patient, and try to keep the assistant non-contaminated, because the assistant has to run the video, the assistant has to run the laser, and sometimes I need other kinds of equipment, and so we have to really try and train how this works together. Then, because I have the paper machine as a belt around my belly, I don't want the belt to be contaminated. That's why I will put on a plastic apron to make sure that the front part is all covered. But if I have a plastic belt on the side here, then I want to rip it off so that it does not get sucked into my respirator machine. Okay, now we're really fully dressed for this procedure, as you can see, and the air flows inside of the hood and comes out here. But because we also could be asymptomatic and contagious, we also have the FFP masks on while we're doing the procedure. And now the procedure itself is the same as we explained before. However, we're now covered more because of, it could be papilloma and as well as the corona infection. Let's show how it works. For the procedure itself, we will not repeat all the steps, but let's say that the patient has an anesthesia in the nose, so you take down, yes, and cover the mask. And once I'm inside of the nose, then I will follow the whole procedure on the screen. And I do have my release button for the laser down here. You can't see it right now. And for the moment when I need the laser fiber, the glass fiber, I will ask the assistant to give it to me, and then I will insert this glass fiber into this inlet and then do the surgery. The only difference between the examination that we showed before and this kind of procedure is that I have to take care of laser safety precautions. Of course, I'm more protected with my hood, but the training and our dual work that we have together is actually the same. So after we're ready and the procedure is ended, of course I have to clean the endoscope with my disinfectant that does not contain any alcohol.
I'll clean it with one wipe and a second wipe, as you can see here. And then you can also use some suction in here to suck out if there's any secretions or blood inside, and then pass it over to the cleaning bag, which goes to the container then for further cleaning. As you can see, also the glass fiber is inside of the flexible endoscope, because this is also contaminated and goes to the cleaning process. After that, I will ask an assistant to open all the windows. I will tell the patient that patient should stay seated. I will take off all the personal protective equipment and then come back only covered with my FFP mask, and then tell the patient what I've done. So how to take off this PAPR and this PPE. First, we want to take off our gloves like this. Throw them away. After that, I disinfect my hands. And after that, I try to get inside of my hood and take it off like this. And usually I have an assistant or somebody who can grab it in here, and then an assistant can also close the machine. I will do that now, and I'll just press this button for 3 seconds, and now it's closed. Then I will hand this over to somebody and also open my belt so that the paper machine is off. I will hand it to an assistant. So now inside everything is safe, which means I can take off my protective glasses. If I want and I feel safer, I can also disinfect my hands again, and then take off the hood, take off the apron, which I will grab in here and just pull and throw it into the bin. And after that, I will, because this was covered, I'm safe to open this like this and then get rid of it like this. If I want to grab here at the sleeve, I can do that. This part was covered by the glove, and get rid of my suit. But if I'm still thinking that I might have touched something, of course you can disinfect your hands again and again. And then you go back to your patient.